At the end of our last class, I felt that I rushed us through the last few national conferences. So I thought I would just briefly go back to them and give you a little bit of sense about what happened in these conferences. Now, you may recall I was telling you that what psychology has tended to do is that as a field, we hold these national conferences every number of years. Most of them are 6 or 7 years apart. And it's to discuss kind of the state of the field. Now, most of the national conferences have really dealt with clinical psychology, and clinical psychology has been the focus. If you recall, I was mentioning to you back in the 1965 conference, people began talking about the need for all the states to have licensing laws, for psychologists to have credentialing organizations, and to kind of better organize the field. Then we went on to the Vail Conference. And you'll see, and the Vail Conference was important because it happened during a time when there's a lot of turmoil in the world and certainly on college campuses. And psychology was feeling this need to develop a way to make the world a better place. And they began to examine, are we really doing as well as we can do? And so the questions that came up, one was, should psychology limit its education to just the usual psychology departments in arts and sciences? And they felt, no, we ought to expand and new models ought to be developed. And so that was when the expansion to medical schools offering PhDs, to colleges of education, of course, had been offering doctoral degrees in psychology all along. But there was a lot of emphasis that that's a good thing. There ought to be more of it. And then there was the discussion about developing professional schools, which is kind of an interesting contrast. In the field of social work and in the field of nursing, those have always been independent colleges, or at least they're usually independent colleges in big universities. Psychology only recently has developed independent colleges and universities and also developed independent institutes that might be apart from universities, but they're accredited and offer doctoral degrees. This was also the time, if you recall, I mentioned that psychology began to realize it was important that we recruit more minorities into the field. And a real change occurred after 1973, and real progress was made. Now, also, this conference said that at least some of the people who actually teach in clinical psychology, especially at the doctoral level, should themselves be practicing clinicians. You might think that that's so obvious. Why would you have to discuss it? And the reason was that there was really a split, always has been a split in psychology between those people who teach in the universities and those people who actually practice psychology itself. And it turned out that we found in some universities that people who were teaching courses like in psychological testing never did any psychological testing, that people who were teaching courses in abnormal psychology really never saw patients, people who were teaching psychotherapy never saw patients, and as a result, they really weren't that up to date. And so this conference began saying, students really ought to be exposed to people who are doing the things that are being taught, and that the students ought to certainly be exposed to the most current thinking in the field. This was also a conference where the PsyD degree that I mentioned yesterday was discussed. And this was the degree often given in independent professional schools. It had to have pretty much the same content as you would get in a traditional PhD program, with the exception that there was less emphasis on research. In some of the programs, you did not have to do a doctoral dissertation, but you did have to learn research methods. You did have to learn the scientific method. And what was substituted for more rigorous training in science was more training in diagnosis and psychotherapy. And of course, that was very appealing and still is very appealing to many students. Now, as often is the case in psychology, the field is always trying to reach out and to do new things. So what was proposed in this was that psychology doctoral training include administration, program development and evaluation, fields that weren't traditionally taught. That never caught on. It's still getting discussed, but the curriculum is so filled that not a lot of this occurred except in a few programs. And also, I believe I mentioned that this conference really emphasized the fact that we have to stop discriminating against people because of their lifestyles. And this is back at the time now when people were still diagnosing being gay as a disorder. And of course, people were realizing that this is utter foolishness. And so there was an emphasis on saying we ought to be open to everyone. And whatever somebody brings, if they're a bright, talented, thoughtful, caring person, they ought to be able to get a doctoral degree in psychology. And, and by the way, that discrimination showed itself in other ways. Certainly there were religious universities that had a lot of difficulty letting somebody in if they were divorced. Or letting somebody in who wasn't of the faith of that university. And that became an issue later on in accreditation, that and for a while, universities, or the American Psychological Association, which is the accrediting body, began proposing we really shouldn't accredit programs if they discriminate against everybody who isn't of a certain religion. Now, a lot has happened over the last 30 years in that regard, and now you find that really is not a problem anymore. But it was a problem not that long ago. Okay, now the next conference then was conducted by the American Psychological Association. And it emphasized accreditation and credentialing, which had grown out of the previous Vail conference, as being very important, and that really all doctoral programs should be accredited by the American Psychological Association. That became especially important because as all of the states ended up with licensing laws, many of the states wrote into their licensing law, you had to graduate from an APA accredited program in order to sit for the licensing exam. So that was very helpful in creating this sense that there ought to be some body that oversees that these programs meet at least a minimum standard. And this conference, like as I mentioned several others, continued to support the idea of the scientist practitioner model. And that goes all the way back to the Boulder Conference, the first one of these conferences we discussed that established the scientist practitioner model. Now, the next conference I'm going to skip over because it's going to come up, the Arden House Conference, which was the conference that really introduced health psychology in an organized way. And when we talk about health psychology, we'll go back and talk about this conference again. But this conference in many ways launched the field. It brought together all of the leading people in health psychology. What was important about this conference, too, is that it did not limit the participants to clinicians. That is, people who were solely researchers in health psychology were very welcome. People who were participants in the worlds of prevention and illness prevention were welcomed. And so the conference had a broader group. This conference also was another conference that began to see we are learning so much. We can't get everything into our doctoral programs, and so they began to propose postdoctoral education. And in fact, there was a group of us there who discussed postdoctoral education there, and then we had a committee, one that I chaired for 2 years, and we came out with a report 2 years after this, so about 1985, with a report that recommended that in health psychology you should have a postdoctoral year of education before you're really ready to practice independently. That, you'll see, is going to come out at several other conferences. We keep proposing that, by the way, but it hasn't happened in the sense that people really have to do that. And one of the reasons is we don't have enough postdoctoral programs yet to be able to accommodate everyone who might be interested in such education. So we keep proposing things, but in many ways the funding is not there to do some of the things that really would be good. Now, the next conference was a conference on internship training, and this shows you the expansion in these conferences. Up until now we're talking about doctoral training all of the time. We've even talked about undergraduate education. But now we're beginning to realize that there are elements of doctoral training that need attention, and the internship was the first one that got focused on. And this conference was held at the University of Florida. And the University of Florida is one of those universities where the PhD program in clinical psychology is actually in the medical center. And what came from this conference were a number of things. First of all, they took the whole picture of clinical training from the first year you come into your doctoral studies right through to the end of your training. And it proposed, again, as the Arden House Conference had, that there be 2 years of full-time training after you get done with all of your practica training. Practicas are where you kind of learn skills in testing, and you learn skills in interviewing and in assessment, and your first skills in psychotherapy. Then you go on for an internship for a year, and this conference says there really ought to be 2 years, and that one of those years should be postdoctoral. And they also said that these internships ought to undergo accreditation in the same way that PhD programs do, because the PhD programs tended to be in universities, and the internships, in the majority, tended to be in hospitals and medical centers. So they felt that the best way to do this is to have an accreditation process for this. And as a reality now, there actually are more accredited internships than there are doctoral programs. So this was a very big step. Also, this conference was the first one to say anyone who does an internship should be funded. Now, you might think that that's a funny one. Why wouldn't everybody take an internship that was funded? Well, what happened was some very prestigious universities actually found that there were a number of people who would be willing to train in that university just for the experience of being associated with a very big name university. They'd be willing to do it for nothing. And many of us felt that that's very inappropriate. I mean, you're working 60 or 70 hours a week. You're very professionally responsible for all kinds of patients. You're at a very senior time in your career. You have everything done except this experience for your doctorate, and here you're not being paid. So as an accrediting body at APA, we decided if you don't pay people a reasonable salary, we won't accredit you. So that's what happened in this conference. Now then, and that conference, as I say, had proposed that there be a postdoctoral year. Well, a few years later, we had another postdoctoral conference. And the first postdoctoral conference occurred at the University of Michigan. The second one, as you'll see, is at the University of Oklahoma. Now, the first conference was really on postdoctoral education in clinical psychology. And it talked about such things as, what kinds of supervision you should have, what kinds of courses you should be able to take, what amount of time should be devoted to clinical work, what amount of time should be devoted to research. And one of the recommendations was that in a postdoctoral year, you should have at least 25% of your time that is available for research. Now, this is important. If you notice, we've talked so much about the scientist-practitioner model. This is saying that as long as you're in training as a clinical psychologist, not only should you be learning to be an expert in diagnosis and an expert in treatment, but you should still continue to develop your research skills. And the second conference then that was held, the one at the University of Oklahoma, was really expanded even further, and it said the field of psychology should look at all postdoctoral training, whether it's to be a clinician or whether it's to take a postdoc in health psychology, where you basically would be learning to do research on health and illness variables, or whether you want to take a postdoc to learn about gerontology, where the whole postdoc would be focused on research, but whatever your postdoc was going to be, that there really ought to be some standards. And it was a very interesting conference because psychology as a discipline had really never talked about postdoctoral education. And it came at an important time because money was then becoming available from some of the National Institutes of Health for people who would do research in very specified areas. The areas that were big at that time, one was gerontology. We're finally discovering people are getting old. Maybe we should learn something about people who are getting old. Also, there were postdocs available in fields like AIDS research because, again, there was so much need to develop programs for prevention, programs of education, so there was a lot of emphasis on a lot of money available for those kinds of postdocs. And there were postdocs becoming available in universities because of research grants where people simply wanted to expand the knowledge base. Now then, in 1990, there was the famous Florida conference, and this was a national conference on the scientist practitioner. And you may recall my mentioning to you that this conference was held, about 40 years after the Boulder conference. And it's really about 30 years, I guess, after the Boulder conference. And what it did is to reiterate that psychologists should continue this theme of training their people who are going to practice to be both scientists and to be practitioners. This was a conference just filled with enthusiasm. It was a fun conference to be at because you had the leading people in the field there, and people really were so united around this idea that it's very important that psychology not give up its tradition of training its people to really be observers of what they do, to be critical of what they do, to examine what they do, to try to improve on our current diagnostic methods, to try to improve on our psychotherapeutic methods. And so this one also came up and reaffirmed in a way what should be in the education of a psychologist. And you'll see these areas: biological bases of behavior, meaning you really should understand what are some of the biological factors that are involved or can be involved in anxiety, depression, schizophrenia, etc. Also, that you should be educated in the cognitive affective bases of behavior, the social bases of behavior, and certainly in individual behavior. You should really understand personality theory, abnormal psychology, etc. And these areas, by the way, are the areas that you must offer in a doctoral program, or you won't be accredited by the American Psychological Association. So no matter what doctoral program you would go into, this kind of education will be provided. This also was a conference that emphasized that people ought to pay attention to what has been scientifically verified as working. If you remember, yesterday I was talking with you about empirically validated interventions, EVIs. And I was saying that there's a real push for the teaching of those interventions where we have some evidence that they really do make a difference, as we have scientific evidence rather than just people's opinions. And this was a conference that also emphasized, people began realizing we offer doctoral training, we offer postdoctoral training. People come out, and as soon as you get your degree, you begin supervising other graduate students and supervising other psychologists. But we don't teach you how to be a supervisor. And so this conference proposed there ought to be some experience where you get to supervise as a postdoc and someone supervises your supervision. So you really learn how to do this well. Now, a couple years before that was the last national conference on graduate education in psychology, and the focus of this conference was to study all of doctoral education. In fact, it was kind of humorous. This conference was put together in many ways as a reaction against clinical psychology. The idea was we spend all our time, we have all these conferences about clinical psychology, we don't talk about other areas very important, cognitive psychology, social psychology. And so this conference got a steering committee, and they chose 8 people. And the chair of the committee was an experimental psychologist, the vice chair of the committee was a social psychologist. There were 3 other social psychologists who were on the committee. I should have 2 social psychologists, another one was experimental psychologist. Then they thought, well, they have to include the clinical world, so they chose Roger Myers, who was a very well-known counseling psychologist, to be on the committee. And they chose Joseph Matarazzo, who many people see as the founder of medical psychology, who is a clinical psychologist, and myself. Now, the 3 of us, the last 3 I mentioned, we were the tokens. I mean, we were on there, but we were not to say anything because this wasn't to be a conference about clinical psychology. And by the way, we were very quiet. I mean, we really let the agenda be set by others. So the agenda was set. And what happened was the conference was almost all about clinical psychology. And what became fascinating was that when you get into controversies in psychology, it always seems that clinical comes to the fore. So even when almost all the delegates were not clinical psychologists at this conference, and the focus was to be on all these other doctoral programs, the focus constantly drifted back to clinical psychology. And in fact, so much so that there was a minority at this conference actually proposed that clinical psychology programs ought to be moved out of arts and sciences departments, and they really ought to be in their own independent professional schools. This came partially because there was so much feeling that the clinical programs were getting so much attention. I mean, often there were more clinical students in a department than there were students in the other programs. The students who were in clinical also were finding it easier to get jobs. And there were any number of things going on at the time. And there was kind of a war going on in psychology. And it went beyond the graduate level. It also went to the national level, where the American Psychological Association, which was the association for psychologists in the country, was being seen as a practitioner organization. And that those people who were scholars and academics weren't really getting the say they felt they needed. In fact, what happened is they started their own organization, which is now called the American Psychological Society. And the American Psychological Society is made up mostly of academic people. Of course, a lot of the academic people are clinical people. So there are a whole slew of people who are actually in both organizations. The irony, and many good things have come from the American Psychological Society because they have their own convention, they give people opportunities to present papers, they bring scholars together, they very much focus on the empirical method. But the irony is that this group was started because they felt that the American Psychological Association wasn't giving enough attention to research. The truth is today, the American Psychological Association, simply because it's a much wealthier organization, puts much more money into research, into studying research, into lobbying the national institutes to put more money into psychology research than the American Psychological Society can. So there's an irony that even though you have this breakaway group, many of the people in the breakaway group were also in APA. And the very reason they broke away, which was to get more attention on research, is actually being carried out as much by the American Psychological Association as it is the American Psychological Society. But that's the nature, by the way, of what happens in professional groups. Well, anyway, a group at this conference proposed we ought to just split these people and let all those clinicians be in professional schools or something else. Most people did not like that, but it became very argumentative at this conference. I mean, there was really a lot of negative discourse. And so on the last day of the conference, I was invited to give a presentation to see is there something that somebody might say that might have some healing to it. So I gave a talk that was titled Science versus Practice, or Science and Practice. And I tried to point out that it would be very artificial for us to separate the clinical doctoral programs, that is the applied programs. And of course, if you separated clinical, that means you would probably be talking about separating counseling psychology, school psychology, industrial organizational psychology, from the very basic science programs that you might think of as cognitive psychology, perhaps geropsychology, social psychology, experimental psychology, etc. But that if you do this, people lose. And the people who would lose the most, actually, would be those people who really want to be clinical investigators. Because if you have to make a choice between learning research methods or learning treatment, you're not going to be in a position to be a very sophisticated researcher. In fact, that's one of the shortcomings sometimes of people who get experimental degrees, is they have great sophistication in how to carry out studies, but they don't know the phenomena they study. And so I felt, and the majority of the people at this conference felt, that we would really lose a lot if we separated these groups. So that didn't go anywhere. But if you notice, I put down that that what also was going on at this time, which affected psychology, was that many specialists were going into other fields. So the neurosciences were drawing away people who were really interested in certain areas of cognitive psychology, and this was worrisome to people because we were finding out that our field is being taken over by new fields that are emerging. And the PsyD PhD controversy continued, which had to do with, again, that movement of clinical people out of universities and into professional schools. Now, right at the end, in our last lecture, I mentioned that there were 3 conferences in Houston. University of Houston, probably more than any university, maybe the most famous conference having taken place at Boulder. The University of Colorado has certainly had real involvement in national conferences. But you've had 3 really major ones here in Houston, where the University of Houston Psychology Department or Counseling Psychology Department have played major roles. The first one was on service needs of the seriously mentally ill. And Dr. Dale Johnson, who is now a professor emeritus here, organized this. This was a superb conference. And it was one that tried to bring in all the caretakers of the seriously mentally ill. So we had psychiatrists and social workers and nurses involved. We even had families involved. And as any of you who are familiar with families of seriously mentally ill people, there is a national organization, the Alliance for the Seriously Mentally Ill. And these people participated. And we discussed a lot of issues. One of the issues was training of psychologists at the master's level, because so many seriously mentally ill people are treated in state hospitals in the country. And in many state hospitals, or almost all state hospitals, many of the people who actually are treating these individuals are people with master's degrees in psychology. And you may recall yesterday I mentioned we graduate about 1,000 doctoral psychologists a year. We graduate 12,000 master's people in psychology in a year. We still haven't figured out any organized way to kind of bring them into the psychology family. So this got discussed because people felt it was very important. We still didn't really get anywhere with it, and we still haven't gotten anywhere with it. Now, just go back here a second, actually. Now, the next conference was an international conference on neuropsychology that Dr. Julia Hannay, who was in the psychology department, was a leader in. And this was a landmark conference for neuropsychology. I mean, it kind of set the standards for what's going to happen in that field. And it began to point out that if you're really going to be in neuropsychology, that first of all, the program ought to be run by an expert. So it ought to be run by somebody who had a diplomate in the field of neuropsychology. And you remember at the beginning of yesterday I talked about the diplomate status in psychology. And that if you're going to understand neuropsychology, you really have to study neuroanatomy, neurophysiology. You need to know psychopharmacology, fields that weren't being taught in many traditional graduate programs. And so this emphasis in this was, if you're really going to offer a doctoral program in neuropsychology, you've got to expand your curriculum, which meant either offer those courses or let the students go to medical schools and take some of the basic science courses in medical schools, which would be relevant for the practice of neuropsychology. Now, the 2001 conference was a conference on counseling psychology that Dr. Bob McPherson, who is the chairman here in counseling psychology, organized. And this was a different conference. This had about 1,000 people at it, biggest of all the conferences I think we've ever had. And this was one where students were invited to get active, and the conference tried to address all of the issues that were current in counseling psychology, which meant their doctoral programs, their internship training, their postdoctoral training, their career paths, licensing, and any other areas that became of interest to them. Now also, as I mentioned, once we began offering doctoral programs in medical schools, then medical schools began to get more interested in having a more organized kind of curriculum and organized experience around clinical psychology. And medical schools had one advantage, and that is you could train people in the medical school, give them their PhD courses, but you also could have them get their early clinical training right in a hospital or clinic setting. You could also provide internships in that very setting, and you could provide postdoctoral experiences. So this became, and by the way, the people who went to medical schools to get their PhDs in clinical psychology were highly satisfied with the experience. Now, there weren't a lot of them. There still isn't a lot of them, but there's the Chicago Medical School has a doctoral program, the University of Alabama at Birmingham, the University of Florida, Oregon Health Sciences University, the Uniformed Health Services University has a doctoral program in clinical psychology. Northwestern University Medical School has one, and there are a number of others, but it's not a large number. But the people who are in it are so satisfied that there has been this concern that perhaps we should have more such programs. Now, the way this developed was that in 1953, so 40 years ago, 50 years ago, there were only 225 psychologists in medical schools. And when you think that there are about 125 medical schools, it meant there's only about 2 psychologists in every medical school back then. 40 years later, in 1993, there were 3,500 psychologists in medical schools, which means on average there was about 20 psychologists in every medical school. And that really showed the growth of psychology moving into health care, not just mental health care, but into the broader field of health care. And that's what really led then to having doctoral programs in health psychology, or in medical centers. Now, the one controversy I didn't mention here that came up in these conferences was also the issue of should psychologists prescribe medications. And that's been a concern for a long time. Now, it's a very complicated issue. It's complicated really by the fact that as we become more and more sophisticated, we get to see that medication really can be very helpful, especially with people who are seriously mentally ill. And for example, especially if someone is experiencing a manic depressive psychosis, we learned that lithium is just very helpful in calming this person down and allowing the person to become less symptomatic, often asymptomatic, and that you need to medicate people for certain disorders. People who are acutely psychotic, especially schizophrenic people who are acutely psychotic, benefited a lot, many of them did, from medications. So psychology began looking at this phenomenon, and there was tremendous resistance. It was interesting history, a tremendous resistance from medicine. And as people looked at this, what we found, of course, was that psychologists actually have been prescribing medication for a long time. psychologists prescribed medication on Native American reservations for many years. And the first programs that began where psychologists got training in prescribing medications was in the military. Now, why do you suppose it wasn't a big issue for psychologists to prescribe medication on Native American reservations or in the military? Why would it be okay there, but medicine would strongly resist them prescribing in other settings? What's your guess? Sure.
Certain prejudices, because in the military, with all this shell shock and this crazy some veterans are, I'm going to say this. I've heard from veterans myself, and through being a veteran myself personally, you go overseas, you fight a war, you go through all these stresses, and come home and you don't see if a hero's welcome. That has been an argument from veterans from World War I and II. These veterans, I've been to the VA centers, they complain, we're in these bad conditions, we don't get the benefits that we deserve and the honor we deserve from our country. And to me, it's not only an issue of money, there's also an issue of the idea, well, there's certain groups that we can experiment on, kind of like the Tuskegee experiment with the African Americans, seeing how syphilis in its advanced stages affects the human mind. We'll do this on the black man at this particular day and age because it was legal, we could get away with it, but I wouldn't try that today because you can't get away with something like that. So to me, when you talk about Native Americans, you're talking about an even more persecuted group of people that are totally isolated, and a military is sort of like an isolated group of people. They don't represent the majority of society. So you can pick these small numbers, see how this works out. If it's acceptable, maybe over time we'll broaden that out to everyone. So we got to see if it's safe first. The guinea pigs.
Well, you know, I think there's certainly some real truth to what you're saying. I don't think that was the most powerful reason for the resistance. What do you think might be even more powerful than this very well-known prejudice against Native Americans, against other minorities? Because after all, amongst the veterans population, many of the people were majority people. Why would medicine resist having psychologists prescribe in settings other than in the military and on Native reservations? Well, now I would think you would come up with this one. Mr. Edmund.
Maybe it's money?
Ah, yes, exactly.
I kind of mentioned the money, but I thought it was more or less the other issue.
You did mention the money, but I wanted to bring that out. You see, if you prescribed on Native American reservations, you were a paid employee. You didn't get any extra money if you prescribed. In the military, I mean, if you go in the military, it's fascinating. One time I was talking with the head of a naval hospital that was closing, and I was in a position where we were looking that we might take over some of these buildings, and I asked the head of the hospital, I said, who prescribes here? He said, well, we're walking through a dental clinic. He said, you know, dentists prescribe, and he says, and physicians prescribe, and nurses prescribe, and medics prescribe, and physician assistants prescribe, and he said, everybody prescribes. He says, I know why you're asking this. It's because you're a psychologist. And he said, that's not a problem for us in the military, because we've been having all kinds of people prescribe for a long time. The issue has been an economic one. And it was interesting for me personally, because when I was the chief of psychiatry outpatient services, I actually taught the psychiatry residents their first course in emergency room psychiatry, which meant that that's the first exposure they would get to how do you medicate somebody in the emergency room. And at that particular time, I really did know a lot about medications and had very good training in medications. And it always dawned on me that if psychologists got appropriate training, and today prescribing medications is a sophisticated world, much more so than when I was younger, and you do need very special training. But there's no question that the myth that physicians are expertly trained to medicate psychiatric patients is unfortunately pushed way beyond reasonable limits. When you're in medical school and you do your residencies in any fields other than psychiatry, the max you're likely to be exposed to psychiatry is 6 weeks. And in that 6 weeks, you learn everything that you're going to learn. That is, you're exposed to diagnosis, to treatment, to medication. You get very little training as a physician in medication while you're going through your medical training. If you become a psychiatrist, often some of the residencies in psychiatry are actually quite sophisticated and do teach people a lot about medication. But back when this became a controversy, it just happened to be that I was chairing the American Psychological Association's Board of Educational Affairs, which kind of tends to look into controversies. And so I appointed a committee to develop what might be a model curriculum in psychopharmacology for psychologists. And indeed, this committee met for long, very, very expert people on this committee, and they developed a curriculum. In fact, they really went overboard, and the curriculum they worked out takes 2 to 3 years to complete. But it became so sophisticated that the military jumped on it, and the military decided that they would train psychologists. And today, psychologists in the military actually can prescribe independently if they've taken this training. And that led psychologists and states to begin seeking this kind of licensure in states. Now, so far, the states of New Mexico and Louisiana have passed laws that license psychologists to prescribe medication if those psychologists have taken advanced courses. And so it's only a matter of time till all the states will eventually, I mean, this is the way all of these things work. Once a couple of states do it, another state does it, and eventually all the states will do it. It's a complicated world, though, for psychologists because it already takes a long time to get a PhD. We are going to have to add on a considerably longer period of time for those psychologists who not only wish to practice diagnosis and psychotherapy, but also wish to prescribe medication. Personally, I think it's a very good thing that psychology is getting into this, but the educational element of this is complicated, and it's going to take a while to get worked out. Now, there already are training programs in psychopharmacology postdoctorally for psychologists. Many psychologists are taking these programs and they're ending up prescribing. But the thing I mentioned before about the prejudice against psychologists is almost solely around the issue of income, because we have had nurse practitioners prescribing psychiatric medications for a long time. We have had any number of people prescribe medications who get no expert training. I mean, for instance, if a dentist wished to prescribe psychiatric medication, I mean, dentist is licensed to do that. There's absolutely nothing in their practice, or next to nothing, that would make them experts in prescribing something, but we haven't kept them from doing it now. But psychology has really represented a threat, so there's been very organized resistance to it. Now that seems to be passing. Let me just... Now that's what I'm going to cover under these national conferences. Are there any questions you want to raise about what we've covered so far in that? Yes. Okay. Okay, now then we're going to move on to a new topic, and that is we're going to talk about some major people who have influenced the world of clinical psychology. And actually, you know, the first person we're going to talk about is not a psychologist. It's Sigmund Freud. Sigmund Freud was a physician, a psychiatrist, the founder of psychoanalysis. And actually, Freud represented such a dramatic step towards the psychological that he is seen as an incredibly significant figure in the modern development of psychological theories of personality, in the modern development of the treatment of the mentally ill, and in the development of expanding our awareness of personality, especially in recognizing that we are more than our conscious selves. And as you probably will recall, actually, how many of you have taken theories of personality? Okay. Okay. Psychology of personality. Okay. Then some of this will be redundant for you, but we're not going to spend a lot of time on it. But But I think it's very important to be aware of the impact that this theory and a couple of other theories we're going to discuss have on the diagnosis of the mentally ill, the diagnosis of people even with other forms of disorders. And also, it's very important to be aware that that the misinformation that is in some of these theories has probably kept us back. Today, for example, as important as Freud is in the history of this, and by the way, Freud has had some very interesting insights I think are quite accurate, but most of what Freud proposed, no one really accepts today. He was the beginning of something, but we've got much more sophisticated understanding than we had back when he first developed his theory. And you have to remember, Freud actually did not develop his theory from any empirical research. He developed his theory from talking to patients and having patients give their recollections of what happened to them when they were very early in their life. And he then built his theory from the observations that he made, but he really didn't have any evidence outside of that. What he did, though, is he came up with many constructs and concepts, and he developed stages of development. And the stages theory, of which there have been many other theories developed, but it was important in helping us to understand that every phase of someone's life is meaningful. And if troubling things happen in a certain stage in life, you can suffer greatly from it for a long time. Now, Freud's theory, was an instinctual one. And as Freud thought that when this little baby is born, this baby has got all these intense feelings inside, and all these intense feelings, by the way, are oriented to self-pleasure. That what the child really wants is to have the world to themselves, to be able to express anything they want, to be gratified at any moment, to be taken care of, and that if the child grew into an adult like this, then the child would simply be demanding that the world be a place solely for them. But, he recognized that that isn't what happened. So he felt there must be some process that takes place in a child where the child learns to adjust to society. So he started off with his theory, which we tend to call a libido theory. Libido refers to all that psychic energy that's in someone that's pushing the person to seek gratification. Now, to understand the dynamics of personality, Freud developed or posited a psychic structure. And it essentially had three elements. And you'll notice in our drawing here that the way this is supposed to look is that top line is actually a water line. And underneath, above, we'll start with above, is your conscious life. And then right below the water is what we call the preconscious life. And what that means is that there is material that you are not thinking about now. It's not part of your conscious life now. But if somebody asked you, you could easily recall it. I mean, if we asked you to name your parents, you could probably tell us their names. If you asked us, where did you go to grade school? There are all kinds of things that you're not thinking about now, but actually, if somebody just asked you on reflection, they're available to you. That material, and it's a vast material that's available. But you'll notice, even more vast is what's under the next line, which is the unconscious. Now, this iceberg concept says that, and when you think about icebergs, most of an iceberg is below the waterline. And in fact, the vast majority of an iceberg is you can't see. And then, if the water is clear, you can see a little bit of the iceberg underneath the water. And then you really, what you see above the water in an iceberg is actually a small part of it. Freud was saying that's how your psyche is. Your psyche is mostly unconscious. So most of what's going on in your life, most of the urges you have that are pushing you, are really not available to you. Now, that then led him to develop a psychic structure. And he came up with three elements. One was the id, and the id was guided by what he called the pleasure principle. What you want to think about with the id is like all these instincts that want to be gratified. And if there was nothing in the way, you would be all id. Everybody would be all id. The problem is, if everybody was seeking that kind of gratification, there'd be absolute chaos in the world. So what he decided was that that the id actually is unconscious. People are really not aware of their id instincts. But in order to function in society, he said people develop a mechanism called the ego. And the ego is that part of the personality that allows id impulses to seek gratification in socially acceptable ways. So the ego actually becomes a mechanism that modifies the id impulses. However, Freud also noticed as he listened to people that there seems to be another thing going on psychologically with people. It doesn't seem to be especially conscious, but does seem to affect their behavior. And that is that people behave in a way that they believe will be acceptable to others. And that world is usually interpreted to a child by the parents. So what you end up here with is a concept called the superego. Now the superego is mostly unconscious. Some of it is preconscious. That is, if you reflect enough, you could probably come up with some elements of your superego. But the idea of the superego was that you learn from your parents that there are certain things that are acceptable, and actually if you do them, you will be rewarded. And if you don't do them, your parents will be angry with you. Now, occasionally you'll read in the textbook, they substitute the word conscience for superego. That's a bad analogy, really, because conscience tends to focus on spiritual values that people have developed. And you have a conscience because you've come to believe there are certain things you should do and there are certain things you shouldn't do. And if you do things you shouldn't do, you'll feel guilty. But the guilt you feel, usually you can reason to, is deserved, you know, in the sense that you actually believe you shouldn't have done this. The superego is simply a mechanism that has interpreted the world to you, and the reason you don't do certain things is because your parents will be displeased, or people who were caretakers of you or important and significant in your life will be upset with you. And so the idea of the superego is that it is there to make sure that everybody behaves in a way that allows them to get pleasure and allows our society to function the way we would like it. Now, there's also a second aspect of superego called the ego ideal. And the ego ideal refers to that part of you where you involve yourself in certain behaviors in order for you to appear to the world as a very good person, and that you will get rewarded maximally for those behaviors. So your ego ideal, in a way, is the person that you think you need to be in the world so that everybody will love you, respond to you, be positive to you, will not be angry with you. And so it's a way you seek a lot of gratification. And Freud posited everybody has an ego ideal, but it differs depending on how the world was interpreted to you by your parents. Now, in our next lecture, we're going to continue to discuss Sigmund Freud, and that will take us into discussing psychoanalysis as a means of treatment. But we'll take a break for now, and then we'll come back.